Good morning again. All of you have joined us in discussion room 2 with Dr. Sean Boynes. Before I give the stage to Dr. Boynes, I want to do a brief introduction. Dr. Sean Boynes serves as the Vice President of Health Improvement at DentaQuest Partnership for Oral Health Advancement, overseeing national programs and initiatives focused on the integration and coordination of person-centered care, and developing and implementing value-based strategies. I want to thank Dr. Boynes very much for taking time out of his busy schedule and joining us today. So I will turn this over now to Dr. Boynes. Thank you, Dr. Boynes.
Thank you, and thanks for having me. Can everybody hear me okay? Good? All right. I like this new Crowdcast platform. I didn't have to touch any buttons. I just stood there and waited for the camera to come on. So kudos to you all. So welcome, everyone. It seems like everybody's joining in and saying hello. So please, yes, use the chat on the right-hand side of your screen in order for us to have conversations. Really, today, what I'm going to do is kind of go through a little bit of history and talk about my own experiences with systems change and also where inequities and the challenge of overcoming them came into play. This will set you up with some of the small group sessions that will occur following this session as the Zoom platform gets launched. So I see people are still coming in and saying hello. Continue to do that at any time. If you hear me talking, this is supposed to be very interactive. So please put comments in. I can see them as they are coming up, and let's have a discussion. So I thought that we would start really with a history lesson in the late 1800s when dentistry was fairly unregulated, and talk about the history a little bit that's kind of led us to the point of having to really enact systems change. So as I said, in the late 1800s, dentistry was fairly unregulated. And as the century turned, there was a desire to really form schools and form some structure, to get out of the fact that teeth were being extracted in barber shops and on the sides of roads, if you will. Around the turn of the previous century, the Flexner report came out. Dr. Flexner was really wanted to set out to establish an educational structure and a learning structure in place. And really, while the Flexner report did a lot at the turn of the century to help with regulation and also with education, it also created a litany of subspecialties. And to many of my colleagues in the primary care field, they'll say this is what led us to the debacle of all of these fragmented processes that we have today. And that includes dentistry, which really was identified as a surgical subspecialty. Now, what was interesting is as we kind of went into World War II and just before, you had Blue Cross and Blue Shield as two separate entities that were selling insurance coverage to individuals. Prior to World War II, about 10% of the population was covered with insurance. As World War II came back and we saw a boom that happened within the workforce, insurance and benefit packages were something that was increased, and employers wanted those as a value-added process for their employees. Dentistry was part of that, although separate as a benefit. And really, what was established through that World War II period was a family-based desire to have some sort of medical and dental coverage. One of the things that happened, as I'm sure most of you are aware, very similar to housing and as the suburbs increased, is that white families were more pronounced to be able to get those benefits. And it really was at the exclusion of persons of color and other families, the same as the housing process and the suburban sprawl left a lot of individuals out. What was also interesting is how the ADA progressed, the American Dental Association, which was really also not inclusive of the process. And in fact, in 2010, the American Dental Association issued an apology letter really saying that there was a lot of discrimination that occurred in those early years. Now, what's been interesting, and I'm not going to pick on the ADA here, I'm just using this as an example because other organized areas of dentistry also went in place. But if you look at 2010 when the ADA issued that apology, there were 3.5% of African-American dentists and 4% of Hispanic dentists within the American Dental Association. Now, the promise that was given within that pledge of that apology was a desire to increase that. Now, unfortunately, although lots of work has been done, the most up-to-date numbers that we have is it's 3.8% of Black Americans that were part of dentistry, and 5.2% that were identified as Hispanic. And so there really hasn't been a lot of progress in that mechanism, if you will. And if you look, we're really off and not representative of the United States overall, with 17% Hispanic population and 12.4% African American population compared to the 3.8% that are dentists. And so there's still a lot of work to be done. The reason that I mention this is the ADA was so influential in the structure of dentistry and the way that it went into local systems, right? You have this national, the state, and then you have these local societies that really helped to shape dentistry outside of the scope of persons of color, that has kind of led us down a process of being very dominated from a white perspective. And so I think a lot of these processes early on with how dentistry was first fragmented, and then the process of how there was not as much inclusion has led us to a pathway of having a lot of inequities in the system. Now, the other thing that's also part of this entire process that we need to address, which really, in my opinion, helps to slow the system's change, is the value of dentistry, or the value of a dental practice, right? This is still one of the conundrums that we continue to have. Yes, Dr. Raymond was the ADA, the first African-American president. Thank you for pointing that out. And that was the reason that went in. I want to point out, I am not picking on the ADA, just telling a history lesson. I am cognizant of all the work that's been done. Just really want to level set so I can explain kind of the processes that are in place of the challenges that I continue to see as we try to bring communities together. One of the big pieces is the value of a dental practice, which comes into play, which is the perception of how much my investment in my practice is going to be, and really what was a retirement value for individuals in order to think about what they're going to retire. So a dentist, and this was true when I was training, it was you invest in your dental practice, you build your patient base up, you build your business up, and at the end, when you're ready to, go on to retirement, you sell your practice, and that becomes a main point of your value. And so part of that process is the patients that are within your system, or the perception of the value of the individuals that are coming into your practice. And so there was a great study that came out of the University of North Carolina in 2001, where they did a lot of qualitative assessment, a lot of focus groups. And I know there's limitations in that, but I think there's a lot to be told whenever you talk to individuals about their experience. And one of the things that came up was this desire to have individuals, white individuals that were influent in the community, as part of your practice. And I see this today. In fact, I was watching the local news. There was a local dentist that came on, and one of our quarterbacks from the Pittsburgh Steelers were there to say, I'm one of the patients. And, it's that perception of a value of somebody who is achieved and has a high financial acumen is attending this dentist office, and the dentist was selling the fact that that person was their patient in order to elevate the value of the practice. And so I think what can happen in that process is that individuals that have the perception of not having that value, which in the United States and in dentistry, because of that history I told you about, tend to be persons of color, to devalue. And this University of North Carolina study really captured that. In fact, there were individuals that said they felt the dentist felt like their kids were dirty and didn't really want to touch, or that they saw that the dentist was shaking hands with individuals that were white, but yet they would not shake their hands. And I'm not saying this is spread throughout dentistry and that every dentist is bad. It's always a bell curve. But I think it's important for us to understand that that exists, and that whether it's conscious or subconscious, those are things that make it difficult for us to enact systems change in a way where people are willing to improve the process. What was interesting in this study, and there's been some other studies that have come out, is that while there's also racial issues that are part of this, there's also a poverty issue that falls into place, or the view of what a Medicaid patient is. In fact, in this study, they found that a lot of patients that are with Medicaid are considered uncooperative or unappreciated. Now, I'm going to share with you, I was a Medicaid kid. So I was on Medicaid as a child. Now, I am white, so I don't claim to understand the racial pieces that are in place, but I can tell you there were times that I would go into a dentist office and feel uncomfortable. It's a big reason why I chose the field that I did, because it did make me feel less than or underappreciated or lazy or things of that connotation. And I think there's studies that have really noticed that. Now, if you look, if you are a Black American on Medicaid, it seems that discrimination is there, where you, as one person put it, it felt like the dentist was paying for my appointment. And if I wasn't gracious and appreciative throughout the whole process, that I felt like that dentist really didn't feel I was equal with another individual. So I think for us to say that it's not there, or it's not in place, is important. And some of the work that you're going to do as you go into the next session around equity, I think these things have to be in the field of barriers and where places that you guys explore as you guys have these conversations. Where there is hope is within us working within a holistic system, where we start to partner with medicine and we start to partner with hospital systems. Now, there's a lot of talk about interprofessional practice and why that is important. It's important for the dental teams to really work with the medical teams. It's also important that where there is true medical dental integration that I have found to be successful, or in programs that we've worked with through either our philanthropy or within our care improvement initiatives, is really where those community support mechanisms come in place and really tries to drive those values home. Yes, breaking stereotypes, Dr. Tawari, I appreciate that, which is very true. I think there are preconceived notions of individuals that come into play based on who you perceive they are and maybe the type of insurance that they have. Now, I can tell you from my example, when we were on Medicaid, it was because the coal mine had shut down. I'm the son of a coal miner. If you've ever seen Harlan County, the movie, my dad is in that. My dad was in that particular movie. And in fact, I'm going to reach back here and share with you. This is from my dad. As you can see, this is the United Mine Workers, and that is Ted Kennedy's signature, who my dad got to work with as they were fighting the boss man. Now, as those coal mines shut down under strike, we had to go on Medicaid, and that was known in the community. And we had to change dentists in order to do that. And I can tell you personally, it was kind of embarrassing to me because I had to go to the Medicaid dentist. And I remember that I felt like that followed me throughout my school. And so those stigmas are real. And I understand and can empathize with a person of color that it might even be more elevated in that process. And so when you see this and you live that and you try to break it down as you go into your profession and you try to fight against that, you really pay attention to these things that are either subconscious or in place. And I think one of the things that I've found to be difficulty whenever you move this process forward is that it's important to understand that in order to enact systems change, you have to make sure that you understand there's a desire to take care of oneself and their family. And so one of the issues that I see are barriers to system change that I hope you guys talk about is there's always talk of not aligning with business or money. That on the systems change side or the public health side, I hear moral compass a lot. And that is implying that you have more morality than someone else. And so when we have been trying to get communities together around interprofessional practice, it really leads to a frustration when you're assuming somebody is bad because there has to be a business model in place in order to do that. I think the other thing that I hear from systems change individuals is the term ignorance. If I just educate this person, they're going to understand. But there is an assumption that the individual on the other side who's fighting against it, is perceived to fight against system change, doesn't have an understanding or doesn't have that education, when in fact they do. And by putting ignorance, you take this individual out. I think the other thing is that you have to think about sustainability through that process. So if there's not a business model that can cooperate with the systems change, that the sustainability doesn't last, which is why we've seen so many iterations of different types of system change in place. Where I've seen success with system change is where it's the community. Most people want their community improved. The other thing is when there's the healthcare system that is the number one employer, I see that work more formidably, where people have a desire to improve their community. It isn't about just changing the system for system's sake. It's about changing the community where I live and breathe or where I work. The other areas where I see it is when the community becomes first and an individual has the opportunity to invest in their community for purposeful gain, there seems to be more attachment. So I share all this. We're getting ready to go to our breakout sessions. I hope sharing my story was helpful. I hope sharing where I've seen success was helpful, and it helps to spur on the conversation as you all move forward into this next barriers facilitators around systems change and also equity. So I think we're almost there. And we can access, if you look at the bottom of the screen, you can see you can access the small group session via Zoom now. So thank you all. I hope this was informative and helpful. And I will be going from room to room, and hopefully I can help facilitate discussion. Thank you all.